Hi, this is Dr. Art Bartolozzi, and I'd like to talk to you about ACL surgery, ACL, anterior cruciate ligament. This is a critical and important ligament inside the knee, and if you look carefully inside the knee, you'll be able to see the ACL, which connects the femur and the tibia. The incidence of ACL surgery has increased dramatically, especially over the past 10 to 15 years, as young people have become much more active. The incidence of ACL injuries is much higher in females, about 7 times more than males, and there are a variety of reasons for that. It's felt that if girls participate in prevention programs, that the incidence of ACL injury can actually be reduced by up to 70%. The reason you need an ACL in your knee is because without an ACL intact, the knee will rock around and slosh around and result in damage to other cartilage in the knee, so that without an ACL functioning, the knee will be basically unstable and it will not allow you to perform cutting and pivoting sports. Now, some people get away without ACLs, but these are the large minority of people. High-level athletes certainly need ACL surgery. Medium-level athletes most of the time need surgery, and most sedentary patients can get away without ACL surgery. So generally, if you're in the younger age range, from 18 to 50, we recommend that you have ACL surgery. In the older patients, and that may be someone who's physiologically older, not necessarily by age, but someone who's relatively sedentary, oftentimes you can get away without ACL surgery. The most important thing to understand is that if you don't fix your ACL, you should not participate in high-level sports. Now, if you don't fix your ACL, you could be at risk for instability even with daily activities like stepping off a curb or stepping down a step, which are the most common provocative maneuvers for people without ACL stability. A partial ACL tear might not result in a loose knee, but if you're an NCAA athlete, it would be very difficult to risk losing a whole season or two and not having your ACL fixed because of the risk of causing further damage. What's happened with ACL surgery through the past 20 years is that the technology has improved so dramatically that now essentially it's an outpatient procedure. It involves a few small incisions on the front of the knee, and rehabilitation can begin within the first week. If you look inside the knee, this is the femoral condyle, this is the medial meniscus, and this is the lateral meniscus, and the ACL is actually inside the knee, way behind the patella. So you can see it's marked in black here, and this ligament attaches the femur to the tibia. There's also a PCL, or a posterior cruciate ligament. It turns out that the ACL is much more important for cutting and pivoting activities than the PCL. This ligament was repaired early on by using a large incision on the front of the knee and by displacing the patella. So a large cut on the knee and moving the patella over. And you may have seen patients with knees with incisions like that. These days, we can do the entire surgery with the knee in place with arthroscopic techniques that allow us to enter from the side of the patellar tendon and to look inside the knee with fiber optic cameras. When you have an ACL surgery, an important decision is what type of graft to use to repair your ACL. And there are basically 2 choices. You can use your own tendon, or a piece of your own tendon around your knee, which is called an autograft, your own tendon, or an allograft, which is from a donor. And each has advantages and disadvantages. The advantage of your own tendon is that it's as old as you are, and not any older. The risk of infection is 0, and the tissue does heal more quickly. The advantage of a donor tendon is it's more cosmetic, it's less painful, there's less surgical time, and you do get better more quickly. However, in the literature, in the published data, there's some discrepancy with respect to which actually works better. And overall, they're about the same, but there's a slight increased performance with your own tendon. So generally we say for the higher level athletes and the younger patients, you can choose your own tendon, and for the older patients, for more sedentary patients, you can choose a donor tendon. But there are exceptions to that. Some people are very small and don't have good tissue to donate, so we would encourage those patients to use donor tendon. And some patients are extremely active or are very apprehensive about using donor tissue. the risk of infection from donor tissue is extremely low, and there are standards via the American Association of Tissue Banks that does govern the safety of these tissues. If we use your own tendon, we usually make an incision on the front of the knee and take out the middle third of the patellar tendon. Some patients say, well, don't I need that? And yes, in fact, you do, but that operation has been done since 1939 in a variety of forms, and it works very well, it's very effective, and it's generally the gold standard. Although now, commonly, many physicians are using hamstring tendons, and you can feel the hamstrings by feeling the back of your leg when your knee's bent. Those tendons, 2 out of the 3, can be harvested, and there's very little downside to using hamstring tendon. If you use a donor tendon, the tissue comes from either Achilles or some tendons around the lower leg, and these tendons are usually substantial and work very well. For surgery, the surgery is often performed as an outpatient. And so you come in the hospital the day of surgery, we go over the procedure, you meet the anesthesiologist, you talk about the options for surgery, for anesthesia rather, and then surgery is performed. You'll be in the post-operative area for about an hour or two. You'll then go down to another area in the hospital where you'll fully recover, and if you feel well enough, you're entitled to go home, and most patients go home after surgery. A brace is applied after surgery so that you'll be in a brace usually for about a week to 4 weeks, depending on your comfort level, and some patients even wear the brace up to 6 weeks. The post-operative brace is applied as a long leg brace, and usually the long leg portion is kept on for a few weeks. The brace can be broken down into smaller components, and so after you're able to walk more comfortably, the brace is basically broken down to a smaller sports-like brace that you can walk with, go to work with, and walk around with. The risks of surgery are the same as risks for any surgery. There's a risk of bleeding, pain, blood clots, infection. So all surgeries do have risk, and we take very special care to make sure that to ensure that these risks are minimized. After surgery, you'll begin physical therapy. Physical therapy often starts after the first week. It's very difficult to do physical therapy within the first week, although some patients do. Generally, we allow you to walk on the leg, use a CPM or continuous passive motion machine, and then do some exercises at home. When you come back to the office, we'll review the arthroscopic findings and review the procedure with you, and then begin a physical therapy program. Physical therapy depends on, and the type of therapy depends on exactly what was done at the time of the ACL surgery. Other things can be damaged, other parts of the knee, such as the collateral ligaments, the medial or lateral collateral ligament, the cartilages, the medial and lateral meniscus, or the articular cartilage. The meniscus can be repaired in some cases if it's repairable, or it may have to be removed. Certain types of tears can be repaired depending on how much of the meniscus is involved, the shape of the tear, and how long that tear has been there. One of the risks of not fixing your ACL is that those tears and those wears of the articular cartilage can become very severe, and that can lead to persistent pain in the knee. The main problem when you don't have an ACL is that your knee becomes unstable with athletic activity. So stabilizing the knee makes the knee stable. A question that's often asked is, when can I go back to play sports after my ACL is fixed? And generally, we say approximately 6 months, but that number varies between 5 and 10 months. Some patients do get back even sooner than that, but now we discourage people from trying to play high-level cutting and pivoting sports too soon because the ligament has to take time to heal, the integration of the bone or graft into the bone has to take place, and most importantly, you have to redevelop the strength in your leg. So we will put you through a series of tests and a series of exercises that verify that you have fully recovered, because the risk of returning to sports too soon is that you might re-injure that knee or possibly injure the other knee. It turns out that there's some data that shows that if you injure your ACL and you have it repaired, your chance of re-tearing that ACL or tearing your other knee can go up over 50 times. So that we're very careful to make sure you're fully recovered, and also that we put you through an ACL prevention program to help minimize the re-injury